I'm here with Dr. Karina Patel, and we're going to talk all things sleep. So, Karina, you're very welcome. A little bit of background, if you may.
Yeah, thanks for having me. So my background is in dentistry. I originally qualified as a dentist and then pretty much straight away cottoned onto the fact that there was more to it. So I essentially did more education around sleep and pain, or craniofacial pain and development, and then went on to open 3 different sleep centers around the world. Now based back in Australia, and here again, spreading more awareness as much as I can around different sort of sleep airway issues. So we have an online platform now and host sort of multiple different lectures on there to try and get as much awareness as possible.
Yeah, we can hardly say in terms of the medical model that sleep has been a success if we look at the compliance with CPAP machine and we also look at the efficacy of adenoidectomy and tonsillectomy. But even before we go there, just for the normal person listening in, what are we talking about when it comes to sleep? What specifically?
So essentially sleep is a massive topic. There's a lot of different hats, I guess, you could wear when it comes to sleep. But specifically with sort of regards to dentistry, what you're looking at is sort of airway compromise and disorders that involve breathing disorders. So things that you can actually see from a dental aspect is essentially what you can see by looking at someone's or into someone's mouth. If there's enough space in there, if they have an enlarged tongue, if it looks like their tonsils are like golf balls, that's literally all things that we can see on a standard examination. And generally those things are written down, but they go no further than that other than staying in the patient's clinical notes. So that's a massive problem because obviously you're seeing the signs and symptoms of potential sleep breathing disorders, but the information is not traveling anywhere, or it's not going to who it needs to go to actually get some sort of treatment for that. So yeah, it's a big problem at the moment.
But it's a little bit bizarre because if you have a dentist who's able to spot, say, for example, the risk factors, I have them, very high palate,
Yeah,
narrow maxilla, retronadia, the maxilla is set back and the mandible is set back, scalloping of the tongue. So
yeah,
my tongue, for example, is the mouth itself wouldn't be sufficiently adequate space for the tongue. No dentist has ever, I'm going to dentists 45 years. No dentist
yeah,
has ever said to me. So I was a child with sleep apnea, a teenager with sleep apnea, an adult with sleep apnea. Now I've
yeah,
greatly managed it and reduced it with practicing of breathing exercise and correct tongue resting posture. And
yeah.
it's just a pity that dentists are not telling their patients, or at least it's not that a dentist is going to diagnose, but the dentist to steer the patient to go and do a sleep study to find out.
Yeah, so that's a massive gap in the learning, especially as an undergraduate. They're not taught anything about airways. There is a small portion that talks about like a connection between sort of pain and jaw dysfunction, but other than that, there is literally no mention of what it could be to have a retrognathic mandible, like you say, so where your mandible's set back and you actually, it has an impact directly on that airspace because it's so far pushed back. There is zero mention of it. So we're literally trying to educate as much as possible to try and get people that are actually noting these things down already to know what to do with that information because they're writing it down, but they have no clue about what to do with it. So, like you said, having a sleep test done, finding out if there is an underlying sleep breathing disorder, and then being able to guide the patient into, who to see to potentially get some resolution. Because even if you are not trained to provide any sort of treatment yourself, you at least should be able to steer them in the right direction. So,
So
yeah.
no, normally a person, they might fill out the Epworth sleep scale or they might do stop bang questionnaire. And I've seen problems with that, and that the man is saying, like, is he tired? No. Am I this? No, 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 no. Everything is no. And he thinks everything is fine. And of course, it doesn't always give a true picture. And if one does go on to a sleep study, in typically the gold standard of treatment is you're put on a CPAP machine. We know the compliance rate is pretty poor. Of course, you're in Australia at the minute, and that's where the invention came out of, one of the best or biggest inventions ever to come out of Oz.
Yeah.
And it was a vacuum cleaner in reverse for the layperson. So basically, you know, you've got a vacuum cleaner which is sucking air, and this is pumping air or splinting air at a pressure to splint open the airways. Compliance is
Yeah.
not good. It's the compliance actually, it's shockingly low. In mouth breathers, it's
Yeah.
as low as 30%, and in nose
Yeah.
breathers, it is higher. It's 70%. So on average, it's about 50. What route would you take with your patients? Because I'm just interested. So you have the CPAP
Yeah.
machine there. Is there another route that people can be taking?
Yeah, for sure. So there's multiple different things that they can do. First is assessing whether they can actually breathe. So if they can actually breathe functionally well, and that means basically breathing through your nose, then that's one thing that we've kind of ticked off the list as, okay, that's something that they can do. Then you're kind of looking further back from the nose and seeing if there's any sort of obstructions elsewhere. So if there's obstructions in, say, the throat, they have enlarged tonsils or adenoids, or something like that. As an adult, then you might want to consider referring to an ear, nose, and throat specialist. But there's things that you can do in-house, potentially like breathing retraining if you're trained in that, or knowing who to send them to for that. There's definitely links between mouth breathing and increased risks of having things like sleep apnea. So trying to reduce that as much as possible. CPAP, yes, it is the gold standard of treatment, but oral appliances have now been shown as another method that you can use for particularly those mild to moderate obstructive sleep apnea cases. So again, it's important to differentiate between obstruction and having another type of sleep apnea, like central sleep apnea, because if your brain is actually not sending the right signals to tell you to breathe, an appliance is actually not going to fix that. So for that situation, yes, CPAP, but there's a ton of other things that you can do for the obstructive. So yeah, the nasal retraining, breathing, oral appliances, and basically correcting the function. If it is that they have a clear airway, but they're just not using it right, there's 100% things that you can do to help correct that.
Such as myofunctional therapy and correct tongue resting posture. You're
Exactly. Yeah.
you're familiar with the four phenotypes or characteristics of obstructive sleep apnea. Um, I find them very interesting. I think 70% of people diagnosed with sleep apnea have either one or more phenotype. In terms of the
Yeah.
application there with tailoring the treatment according to, so for example, I suppose the questions that I would have is somebody who's coming into you with insomnia,
Yeah.
is it tricky?
Yeah. So yes, it can be tricky. And we had a bunch of patients who were actually basically they had PTSD. They were ex-army. So all of them pretty much had a case of insomnia as well. And there you've also got the psychological component to consider, because insomnia is obviously you're not being able to get to sleep, stay asleep, wake up rested. And to correct that, sometimes it's more than just the breathing. So there's other things that come into play. There are, different questionnaires you can use to assess that as well. But like you said, they can be subjective. So you've actually got to ask some of these questions to your patients in person, to be able to see if their mind's racing at night, stopping them from falling asleep. And then the whole other part of that is obviously it can be breathing as well. So that brings it back to the sort of sleep disorder, breathing type issues that contribute. So your body's actually saying, hey, actually, if I go to sleep, I might suffocate. So I don't want to go to sleep. So that's a different situation altogether as well, which makes it even more important to actually get tested if you're someone that does suffer with chronic insomnia. I'm not talking about maybe a couple of nights you can't sleep because, you had a bad day. I'm talking about it being a chronic problem. Then 100% you should get it tested, because you don't know if there is an underlying medical condition.
Is that
So
when it goes,
yeah.
when you talk about chronic, is that when it goes on for weeks and weeks and weeks? Is it months or?
Yeah, so chronic problems, they can be classified in a couple of different ways, but one of them is the length of time that it goes on for. And then the other one is it can actually change the way that your nervous system functions over time. So the actual nerves that help you, that travel to your brain to signal you to actually breathe, they can change the way that they respond if it's been a long enough period. So there's two different ways, but essentially, yes, the length of time would be something that you could look at.
It's a little
So
bit like a
generally,
vicious circle, isn't it? If there's dysregulation of the autonomic, so poor sleep is really going to adversely affect the automatic functioning of the body. And then when
yeah.
there's dysregulation of the autonomic nervous system, it's going to feed into poor sleep. So now you have
Mhm.
this circle.
Yeah, and
Um,
it's exactly that. It's trying to break that cycle to normalize function and get you actually functioning in a what we call parasympathetic way. So you're actually back into where your body can self-regulate. Because a lot of these patients are in this fight or flight state and they actually can't get out of it without some sort of intervention.
and do you use breathing training in terms of helping to bring balance, or do you use other device? Do you use, for example, electric stimulation or not? The stimulation of the vagus nerve,
So
yeah.
So I have had a couple of patients who have been through that successfully. My sort of personal sort of treatment wise would have been to basically start retraining breathing. So, and a lot of people, I think you actually might have first brought this into my head 10 years ago. But a lot of people concentrate on the oxygen and having enough oxygen, but actually looking at, carbon dioxide and how that functions to then normalize the oxygen intake if you are over breathing, which a lot of us do, which I'm probably doing now. But it's basically retraining that to allow your body to actually regulate properly.
Yeah, I think the carbon dioxide is an interesting one in sleep. Um, because if somebody stops breathing, of course, carbon dioxide is going to increase in the lungs and blood. And if they're overly sensitive to it, when they resume breathing, then they hyperventilate. And
Yeah,
then their CO2 levels can go from too high to too low. And then
yeah, very
the
quickly.
brain may not send a signal to breathe. It's one of those things where breathing during the day is forgotten about, even though it's a sleep disorder breathing.
Yeah, yeah, and like whatever you do during the day, it will travel through, which is why a lot of the practices are to try and do certain exercises while you're actually functioning during the day, and then also before you're actually heading off to sleep, to get your actual body in the habit of breathing properly, so that you carry that through the night. A lot of the sort of some techniques that just get you functioning or just focus on the practice right before you go to sleep. Sometimes that's not enough. You do actually need to practice it during the day to actually change a habit. A hell of a lot of times to change a habit. So if you're
There's a
wanting
lot
to
of
do it
challenges,
quickly,
and you throw alcohol and what people do as well, it's kind of,
yeah,
and I suppose it was the bizarre thing when you think about people doing a sleep study, everybody is doing it without alcohol. But if you have a man that's drinking, or female for that matter, drinking 3 or 4
yeah.
nights a week, that's going to impact their sleep, but it doesn't come up in the sleep study. Um, yeah, so you're I'm interested in terms of your approach then. So you're looking at switching from mouth to nose breathing on a permanent basis. Have there been many people in your experience that have not been able to breathe functionally through their nose? How common is it that you would have to refer to ENT?
ENT referral actually isn't as common, especially, well, actually with kids, it's a little bit different. So with kids, if they have enlarged adenoids and tonsils, and you're doing some of the breathing retraining or even myofunctional therapy and introducing that and introducing some expansion, you do actually see a lot of that enlarged soft tissue start to shrink. So then and a lot of parents actually do not want their children to undergo surgery, surprisingly, if they can avoid it. So it's something that they kind of try as something that you you do ahead of actually going under the knife, if that makes sense.
No,
Whereas
Karina,
with an
totally. Sorry.
like, yeah, that's fine. With an adult, it's a little bit different. You haven't got that growth potential. You're pretty much already formed, and you're you stop producing those new cells and everything after about the age of 26. So it's a bit different for an adult situation. So if you have, and I had this actually, I can tell you my own story. So I had enlarged tonsils and adenoids from I want to say since birth, probably. And I had a primary school teacher or a kindergarten teacher actually look down my throat one day and actually comment to my parents, "Oh, how are you breathing?" So I remember it being something that was constant, but there was the health system at the time. I don't know if anything's changed there, but you had to present to the doctor. I think it was like 3 times that year or something like that. And I didn't have tonsillitis. I just had enlarged soft tissue. So it wasn't pussy or anything like that. So it didn't fall under the criteria of having anything done. But then as an adult in Australia, I'm still having the same problem. I can't have anything that was like too cold at night because it will cause like pain in my throat, that kind of thing as well. And I actually ended up seeing an ENT specialist here, took one look at them and said the same thing. How are you breathing? I don't know. So did actually have them removed as an adult. It's a different procedure. It is like a bit more downtime. But I can definitely breathe now. But that
Yeah.
accompanied with the breathing retraining is what it took because I had been dysfunctional for a very, very long time. And I'd been basically chronic, like we discussed, for years. So actually having to, I cleared the path for breathing essentially, but I still had to retrain on how to breathe properly because I hadn't been for so long.
You must be a very bright girl because to get through dental school with a inadequate airway is pretty difficult. I had a trouble get through university and it's not dental school.
Well, on average, I would have had, I reckon, about 4 hours sleep a night from the age of definitely from the age of about 13, 14 till till I moved to Australia and had my tonsils out. So 26. So yeah, it was a long time. No sleep and
You
just
know,
functioning.
and your school teacher, that was an amazing observation. I have actually never, you're like, this is the first time
Yeah.
that I've heard that a school teacher literally just took a look into the child's mouth and was able to spot. Maybe the school teacher had children of their own and knew it from that. I don't know. But
Yeah,
that's an
quite
amazing
possibly.
observation.
Yeah. So I had known pretty much, and people don't know this, but I had known for a very long time, and I just couldn't get the help that I needed because I didn't fit the criteria.
It's terrible
Um, yeah, yeah,
because any child that has a compromised airway, as you know, there's 10 times the risk of learning difficulties. And if the child is
mm,
having sleep issues early on and not addressed by age 5, it can affect brain development. I'm going to come round full circle. You spoke about adenoidectomy and tonsillectomy. I put my daughter through it. Big mistake. Never do it again. And I like that
yeah,
I followed the advice at the time. And it was me that kind of insisted with it with the ENT, so I wouldn't be blaming the ENT at all. It was myself, and that was, the knowledge I had 10 years ago. You
yeah.
spoke about when we can get the children breathing in and out through the nose with palate expansion. So you're
Yeah,
helping develop the maxilla not just in width but also forward growth to help open up the airways.
yeah.
The child then is able to breathe through the nose.
Hmm.
And by breathing through the nose, the nitric oxide and the moist warm air that's coming in is less traumatic, maybe, to the adenoids, but the adenoids shrink, which are
Yeah,
inflamed lymphatic tissue. And the tonsils also are going to be less traumatized by breathing through the nose. And now
yeah,
the child is in a huge, very important place because they have correct craniofacial development as a result of the nasomaxillary expansion,
yeah.
and they've nasal breathing restored, myofunctional therapy restored. They still have their adenoids and they still have their tonsils.
Exactly. Yeah.
Do you know,
Yeah.
so maybe for say parents who have just got it done, and of course you'll be in the same boat as me, and I'd never put, never for a parent to feel guilty about it. That's the way it is. Sometimes you learn about information afterwards. Um,
Yeah.
but the efficacy of it is Karina, it's
Oh,
27% of children cured by having their adenoids and tonsils removed of sleep apnea.
yeah. Yeah.
S-
And there's also an issue with some of the testing criteria as well. So not only is it difficult to actually basically prove that you've helped with their sleep apnea, it's difficult to get a diagnosis in the first place. Um, the criteria is different for children compared to adults, and they only need to basically stop breathing or have a partial airway collapse once for it to be an actual apneic condition for a child. My go-to, I guess, saying that I always say is if you're noticing that your child is mouth breathing or snoring's a big one, go and get it checked out. Because you don't know if it's an actual problem, if it's something that can be cured quite easily. For example, if it's like an allergic reaction that's causing inflammation of the soft tissue, and that just needs a bit of help to be, shrunk down. Or if it's a bigger problem, and if you get to it early enough, you can actually help their development and their growth. And it's not just, what you see on the outside, it's all the internal things as well that are happening, and they're forming all of their, and to have a look at some of those key signs for parents at home, especially.
I kind of lost you, but I think the gist of it is you shouldn't hear a child breathing during sleep, and the child should be breathing in and out through the nose.
Yeah. Yeah.
What if a parent has adenoidectomy and tonsillectomy done with their child, but the child continues mouth breathing post-surgery? Because I don't think there's too many ear, nose, and throat doctors who actually follow up with respiratory rehabilitation or myofunctional therapy. What's the
Yeah.
consequences there? Because it's not a walk in the park. Tonsillectomy and adenoidectomy it's not an
Yeah.
easy procedure.
Yeah. So it definitely requires that follow-up care. Just making a clear path is just one part of the puzzle. You're kind of going halfway there. And if you're going to go through a surgical intervention or put your child through a surgical intervention, you'd want to make sure that it's sort of follow through the whole way. An ear, nose, and throat specialist isn't going to be, that's not their sort of scope, is different. It's outside of that. So their interventions are purely generally surgical and minimizing soft tissue. And they could sometimes, prescribe like nasal sprays and things like that. But when it comes to the follow-up and retraining, it's turned more into the scope of myofunctional therapy, to be honest. And there's more and more popping up around everywhere, pretty much. So there were more in the UK when I left, and there's definitely more coming up in Australia now. But that follow-up care needs to be done. And I would actually suggest seeing a myofunctional therapist beforehand. So before you actually go and have that surgery done, make sure that you're starting to, or get your child to learn or take part in some of those exercises so that they can then follow through. If it's something you've just had a surgical intervention and then you're trying to do all these exercises and they're all completely brand new, it's so much harder. You won't get very much success straight away, and it will take a really, really long time to get there. Whereas the prep work is actually worth it. So yeah.
Myofunctional therapy, it's been around a long time. For people who may not be familiar with it, what does it involve? What's it targeting? What sort of exercises?
So there's different exercises. It does encompass, the idea of it is basically to correct function. So there's different signs and symptoms that you might see. Low resting tongue posture, for example, is one. And if your tongue rests low and it isn't basically, it's not supposed to be pushed up, and that's a really common, like a misconception. It's supposed to gently rest in the roof of your mouth. So there's a lot out there as well, probably on social media and everywhere else, to say push your tongue up, but don't push your tongue up. Gently rest it in the roof of your mouth. The idea is to basically create enough force. Your body's got the power to create enough force to actually allow you to develop to your full genetic potential. So if it's not functioning correctly, that just won't happen. So myofunctional therapists create a bunch of exercises, usually get you to do a program with them. And they go through from the simplest exercises where you're just basically strengthening your outer muscles, like your lips, lip muscles, and then go through to tongue as well. They also go through some breathing retraining. So all in all, that is basically what you would need to do to correct a habit, is look at the function of certain muscles as well as the breathing, because they go hand in hand. You can't sort of treat one without thinking about the other.
And they go hand in hand because even if you treat a nose, it doesn't necessarily ensure that the child or adult is actually going to breathe through it. So that's where
Yeah.
the behavioral change is very, very important.
Yeah. And it's really simple things and things that the children actually enjoy, like blowing up a balloon. Like, I mean, it's really, really simple. Or, blowing a whistle, or there's, child-friendly exercises. I'm not talking about, lifting weights and going to the gym. I'm talking about really
Sure.
simple things that you can add in to their daily routines that they're actually willing to do.
When people are talking about a dentist and a dentist who understands airway, how would you go about it? So, say for example, and I'm not sure how comfortable you are in terms of talking about it, but if you have, say, a child who's with overcrowding of teeth,
Mhm.
and the parent is deciding, well, I don't feel comfortable if my dentist is saying to have teeth extractions. In other words, the different options that parents should kind of consider if you feel comfortable
Yeah.
about it in terms of the right approach for that parent and child.
Yeah. So I think it's important to consider that there are also situations where things can be inevitable, but this day and age, there is a whole range of different options that, that should be sort of more out there than what is currently basically pushed forwards. So extraction, yes, it has had I think it's had its place in the past, to be honest, and things are actually changing. So there is a possibility of actually like opening up and expanding your maxilla, or the top jaw. Um, when you do that, you're actually creating enough room for the teeth to fall in place. Some of this might have happened because you have incorrect function. So if you are mouth breathing and you're not actually having the correct force from the tongue, for example, then things will start to collapse in. So to actually allow that to any of the treatment that you're doing to actually stick or stay, it is important to make sure that you're correcting the function alongside doing any of the sort of expansive techniques. But there's different ones that you can use. So there's simple removable ones, like myofunctional appliances. There's things called orthopedic appliances, which help to correct the function, and they can either be sort of fixed in the mouth or they can be removable as well. The removable is something to consider because the more it's removed, obviously, it's not going to work. So you need to make sure that if you're using a removable appliance on a child, for example, you have the compliance to actually make
Mm.
that appliance work. Otherwise, you've just pretty much
I've been
wasted your
there with
money
my
on.
own, and I have to say it was a challenge. I was going to say it was a nightmare. I'm not sure quite it was a nightmare, but
Yeah.
it was a challenge.
Yeah, so there's there's definitely pros and cons to it. I mean, one of the pros is that you can clean easily. So you're not going to end up with masses of tooth decay and all of that kind of stuff because you can get it out and actually clean around it. But yeah, the compliance is another thing that needs to be considered as an issue. The fixed appliances generally consist of a fixed appliance that is in the palate. And they generally either come with a turn screw or something like that that you slowly turn to get the expansion that you need. The key word there is slow, because I know that there are rapid expanders as well, which can lead to other problems. So the problem is, I think, where to find these specialists or people that have actually had further training in this. But what you'll do is, and parents, I don't know a single parent that actually doesn't get a second opinion, actually. But when you're getting a second opinion, you're looking for basically someone who advertises that they do this kind of treatment. So usually a traditional orthodontist will not be doing this kind of treatment unless they've had that additional training. So, and they are quite open with it, like they'll put it on their website if it is available, or you can always call and inquire. So I think those are really important questions to ask, whether they, like what the treatment philosophy is, what the actual practice believes in before you go and book that appointment. Because the worst thing is that you've booked in for a consultation, you've been there, you've paid the fee, and it's not something that you were actually wanting to do. So to get that information beforehand is what I would say try and do.
I'm just thinking that any dentist who understands about airway is going to have two things on it that may differentiate them from another dentist. One is the importance of nose breathing. So they
Yeah,
will have some indication about breathing training. And the second is myofunctional therapy.
yeah,
So if their
yeah.
website includes nasal breathing and myofunctional therapy, well, you know that that practice then is directed towards more airway centric.
Yeah. So we're actually, funny you mentioned this, that we're actually putting together a directory. It is Australian based, but we will have like a international section. But just to allow patients to find healthcare providers, and I'm not just talking dental, I'm talking sort of chiro and postural workers and people like that as well, who have the same philosophy essentially. And I think when I say philosophy, it sounds like something that we're just doing that's like outside of the box. But there is research and there is, you see it clinically as well as the research. So, yeah, I'll let you know actually when that goes up.
Great. No, that would be super. It was funny, like I went in PubMed there about I was a couple of months ago, and I just put in malocclusion, oral breathing, and it brought up something like 750 papers. In other
Yeah.
words, there's a connection between oral breathing, which mouth breathing, persistent mouth breathing, and overcrowding of teeth or crooked teeth, malocclusion. The debate still kind of goes on a little bit, which is is it that the child is born with a high narrow palate, which in turn there's not enough room for the tongue and the roof of the mouth. The nasal cavity is infringed, and as a result, the child is going to mouth breathe. So it is the development of the child early on which is causing mouth breathing, or is it the mouth breathing and soft food and tongue tie and inability to breastfeed, which is contributing to the craniofacial? So the debate is the chicken or the egg, but it doesn't really matter, does it? Because a functional
No.
dentist is in a position to do something about it.
Yeah, so I would say it's whatever you've noted first, deal with it. Because whether or not you're kind of looking at what came first, the thing is that it's all there. So whether it's that something came first or second or third or last, it won't make a difference, because you're seeing all the symptoms and the signs of everything when they present to you. So, and unraveling those one by one and doing all the things that you need to do to get that patient better, it's the system that you do it in is not going to change because of what came first.
Good, good point. Um, on
Yeah.
a very simple level, dental health. Do you see a
Mm.
difference with mouth breathing versus nose breathing? I, as a child growing up, the dentist used to always give out to me and say that I was eating sweets, a lot of sweets. I was eating sweets, but a lot of
I was like
sweets.
going to say, were you?
But
There was actually, I think it was 2019, I want to say, there was a journal, Pediatric Dentistry, and that actually highlighted the link between chronic mouth breathing and a higher prevalence of dental caries or decay, particularly in your back teeth, because of the reduction in salivary flow. So your saliva is designed to actually protect your teeth, by keeping them moist and reducing the amount of basically bacteria that sit on the teeth. So then what they found is that the actual microbial content of the saliva was different in those patients that chronically were mouth breathing.
So I wonder in time then, are dentists going to have standard advice? So they talk about dental hygiene in terms of making sure that you're brushing your teeth, etc., etc. But I'm wondering, is it going to have another piece? Make sure you're breathing in and out through your nose to protect those same teeth and your gums.
I mean, that would be great. We'll
It would
see
be
if it's in our
great, so it
lifetime.
would. It would be great. I wonder
Hopefully,
what
before we're dead and gone,
do you
this will
think
be
Colgate would sponsor it? You don't have to answer that,
probably,
by the
probably not.
way. So yeah, so just bringing it full circle, Karina. So we talked about pediatrics. I think that's all really, really interesting. I'd say it would be fascinating for. I know, when I came across it was back 2006 or seven, and I would say to parents, and they were almost in disbelief to think that the growth of the child's face is going to be influenced by how that child breathes.
Mm,
Do you think that awareness
yeah.
has moved?
Um, I actually had an interesting conversation because the last webinar that we did was on child development with a pediatric ear, nose, and throat specialist. And I actually thought, why not? Why don't I invite the daycare educators for my baby, see if they want to actually listen. I was actually shocked at the response. They were so into it. They wanted to know. So I think because it's not out there and it's not mainstream doesn't mean that people don't want to hear about it. So, and it was just something I thought, well, I'm because maybe I'm always talking to them about, like I was really concerned about her sleep schedule and whether or not she'd had, the right amount of sleep and whether her mouth was closed and, you know, that kind of thing. Maybe they were just thinking, why was she asking us these questions? But um, all in all, I was shocked at the response. So I actually think the route to go with spreading more awareness is more public awareness, to be honest, because when the public are asking for resolution, then the healthcare professionals will have to kind of follow suit and find out what it is that the public are asking for. So I think that's a more recent like revelation in my brain because I'm used to just doing healthcare education and doing courses to teach healthcare professionals. But I think it kind of has to come from a different approach for it to actually be sort of seen and heard.
Yeah, I agree with you. I
Yeah,
think it is going to be driven. It's a grassroots up.
yeah,
I think it will be. I think there's still some, a little bit of way to go in terms of awareness. The awareness has improved dramatically via books. So
yeah,
James Nestor's book, of course, was a huge kind of advocate of the importance of nose breathing and the effects of mouth breathing and consequent development in the face. Do you think a child is going to reach their full potential if they continue to have mouth breathing patterns with poor sleep?
no.
No, I would agree.
Definitely not. And even I was going to say, even just looking at myself, I mean, most people think that I'm quite bright or and I just think, well, if I was breathing properly, then where would I be? I mean, I don't know. So, and I still have like I haven't actually gone through the route of having my orthodontic expansion and things like that done. I've done the breathing retraining, but it's a whole other process to go and do that. And living in different countries and everything, I just haven't had the time. But I would advise that if you have been in the situation and you haven't had a chance to correct it as a child, definitely look into if you have the time and resources, it is going to make a difference.
It is like you're saying you achieved, but I'm just wondering because if I compared myself to going through university, I got through university too, but it could have
Mm,
been a lot easier, Karina.
yeah,
And there's a lot of
yeah,
kids. I would have to assume that you were pretty driven. You put in the time, you put in
yeah,
the effort, you overcome the obstacle of the sleep issues. I did it.
yeah.
But how many kids will do that? you know, and that's the
Yeah.
other question, isn't it? Yeah.
Yeah. So, and I think that comes from, yeah, essentially like your passion and your drive, I guess. But the problem is that a lot of patients that or children that don't have basically don't have things aligned for them,
Yeah.
they're not going to be in the same situation.
Yeah. Yeah. Yeah.
Yeah.
Yeah. And yeah, it's really it's amazing, you know, if our education system and the primary school teachers and the high school, the secondary school kid teachers were in a position just to identify the instance of mouth breathing in the childhood population, send a note
Yeah.
home to the parents and ask the parents, but then where would the parents bring the child? Because if the parents goes to the GP and the GP isn't trained in the importance of nose breathing, it's not going to
Yeah.
happen. So
No.
it really is. I suppose it's for parents to do their own research on it. Most parents, they have an education now that wasn't like 50 years ago, especially say in Ireland.
Yeah.
And when you have educated parents, they can read through the literature themselves and they can get an
Yeah.
understanding of the development of the face, the impact that sleep and breathing both go together,
Yeah.
has in their child.
You know what the funny thing is? I reckon so 90% of parents that come in, they know something is wrong. So they've gone online and tried to search for because they have, I mean, you get that gut feeling, I guess, as a parent, like there isn't something, something's not quite right. So you do look into it. And when you do look into it, then these things, they are more available than what they were.
Sorry, there's slight technical difficulty there. Karina, I just one question before we kind of wrap things up, because I think it was a really good conversation, both for adults and also for parents of children. I was working with a parent and child about 3 weeks ago, and it was my first visit with the parent and child. And
Mhm.
I was talking about the importance of nose breathing for the child, and the child wasn't in the room at the time. And when I was talking to the parent, I was putting the connection between mouth breathing and how it can really impact academic achievement. And then I was looking at different objectives or different options. So, for example, in terms of development of the jaws, maxillary expansion. And I felt at the end of it, I just came away from it, and I felt as if the parent almost that I went in a little bit too far in terms of did I scare? I was only thinking about it afterwards. Did I say too
Yeah.
much that I scared the parent a little bit? And that was my intention. Do you
Yeah.
ever, what way is your, so for say, for example, your approach with working with a parent for the first time and conveying the information, or do the parents already know a little bit, as you said?
Um, some of the parents already know a little bit. Some of them, there is a case of starting the education from scratch. Um, the only thing I would say is that you have to introduce one concept at a time because it can be
Yes.
overwhelming. Um, so just or I would say, just introducing them to the fact that of what correct breathing is and just the impact that it could potentially have and and so sometimes I would do for, I would say, the newbies, a second follow-up consultation, and I might just send them home with something to do for the after the first. So basically, look at these set of indicators. Are they sleeping with their mouth open? Are they snoring at night? Is there drool on the pillow? Do they have irritability in the morning, that kind of thing, and get them to do a checklist. Because then what you'll find is once the parents start marking off the checklist, they're suddenly interested in everything else because they're seeing that actually the child is exhibiting a lot of these symptoms. So the second conversation is a lot more productive than that initial first one, because yes, you can end up scaring someone
Yes. You would
if you
think I
go
knew
to
that after 22 years of working with parents and children. But it was just that one situation,
yeah,
you know. So,
yeah,
uh,
it can be overwhelming.
yeah, no, I can because I can only understand it.
Yeah.
You know, with your own child as well, you feel very uncomfortable when you're being told this for the first time. you know,
Yeah.
so because so I think it's a shock sometimes.
Mm.
Yeah.
Yeah. And it's definitely that. Like it's a shock that someone's it's probably a feeling of should I have known this? But what I would say to parents out there is no, because
Mm,
some professionals don't even know this. So there's no need to feel bad. At least you're sort of discovering this information now while you can still do something. So yeah.
totally. As opposed to me when I was 28 years of age, you when you were 26 years of age.
Yeah.
So we're, and that's why
Yeah.
we're in this field, by the way. Most,
Yeah.
I find that um, most of the dentists and other healthcare professionals that I meet when I talk to them, they normally go down this route because of their own issues or because of the issues that they see with their children, which is really interesting. So it
Yeah.
wasn't from a theoretical aspect, it was really an experience, you know, in terms of it. So, Karina, last sentences or last words, just tying it all together, and how might people hear of you or come across your work?
So I am contactable through Sleepwell Australia, New Zealand. And if there's any sort of questions or anything, I actually had a patient from 13 years ago reach out to me through the contact form on that last week. She's now in Dubai and wanted to know if I knew anybody there that could help with her son. Um, and actually, I will just touch on that because that was a really interesting story and probably one of the most scariest stories. So her son was 2 years old at the time and he was turning blue in the night, completely stopping breathing. And they take him to accident and emergency. Obviously, he's awake at that point. They can't see anything wrong with him, and they kept turning him away. And, this was like 6, 7 times before she came in and was like, can you see anything wrong with him? Because we just keep getting turned away, but he's definitely stopping breathing because he turns blue. So, but anyway, 13 years later, this same lady reached out to me to find out now he's like ready to move on to the next step with what he was doing. So I think he's now she's looking for someone for his sleep, so who can retest him with a sleep test in Dubai. So yeah, had to look into
But
that.
it's
But
scary
yeah,
stuff.
definitely reach out.
You know, it reminds me of the paper that was written by Dr. Christian Guilleminault, Death and Nasomaxillary Complex. And he looked at 7
Mm.
young infants who had died as a result of sudden infant death syndrome. He concluded that all children died because of hypoxia during their sleep, and they all
Yeah,
had craniofacial abnormalities which reduced their airway, which contributed
yeah,
to their sleep. And something could have been done about that with all of those kids. Like, it's shocking. Um,
yeah.
you know, we're kind of ending on a kind of, well, I won't say a negative note because we'd love
No,
that this talk that we had is going to plant a seed, or at least, you know, kind of direct parents to just delve in a little bit, do your own digging with this one. You know, it's really, really important.
yeah.
Um, Karina, it's been a pleasure. So it's been great. I enjoyed the conversation.
Thanks for having
Um,
me.
yeah, sleep well, Australia, sleep well, New Zealand.
Yeah,
Are you online, by the way? Do you have social media or anything?
yeah. So I think we're even on TikTok now, which does make me cringe a bit, but I'm on it. But yeah, so there is I think Instagram, the usuals, Instagram, Facebook, LinkedIn, TikTok. Yeah, it's across all of those things now. And what we're aiming to do is, like you said, just spread the awareness, plant the seed, and get people hopefully the help that they need. And we have different speakers for, free webinars every month on different topics. And the next one's actually on developmental reflexes in early childhood. So, I mean, all the different parts of the puzzle are all coming together, and those are sort of free and viewable for anyone. So, yeah.
Right. Pleasure, Karina. Thank you very much.
Thanks.